So greetings everyone once again and welcome to the 113th session of the online Optom learning series or OOLS. And today we have with us Dr. Duratul Ain. She is an optometrist by profession. She graduated from the University Kebangsaan Malaysia, UKM in 2000, Malaysia. And then she has worked at various public hospitals in and around Malaysia. Recently, she has taken up the position at the Allied Health Science Division at the Ministry of Health Malaysia as a Senior Principal Assistant Director at the Quality and Standards Units of Practice section. In addition to this main role at the ministry, she continues to be responsible for the expansion of primary eye care at public health clinics in Malaysia. She has also coordinated the nationwide amblyopia and visual impairment screening, which is commonly known as AVIS KKM program, and also the cerebral visual impairment services at various ophthalmological clinics. Dr. Duratul has special interests in public health optometry, which led her to conduct a preschool vision screening program using the Lia symbols chart, which was a master's project, and later at a PhD level, she has developed and investigated comprehensively the effectiveness of optometric services pathway at primary and tertiary levels in Malaysia. And today, Dr. Duratul is going to talk to us about evaluation assessments of children with cerebral visual impairment. So welcome, Dr. Duratul, onto our platform. Thank you so much, for taking up this time.
My pleasure.
Let me leave the screen time to you.
All right. Thank you, Mr. Fakhruddin. Assalamualaikum to you and good evening or good afternoon to everyone. Thank you, Fakhruddin, from the online optometry learning series. I'm actually overwhelmed to know that he actually the mastermind behind this valuable and remarkable work. So congratulations. So thank you again. Now the topic is about cerebral visual impairment. There's actually hope for them. I'm not sure whether how many of you have encountered children with CVI during your maybe employment, your exposure at clinical work. So this is going to be the sharing station from Malaysian experience, right? This is in Malaysia. We started back in 2017 March from that a conference with that time a neuro-ophthalmologist pediatrician from the United Kingdom, Great Ormond Children's Hospital. Mr. Richard Bowen, he came to Malaysia to a conference where he gave this idea and a plenary talk about CVI. So from there on, our late ophthalmologist, Dr. Joseph Alagaratnam, have the idea that we need to start this service in Malaysia. So it was novel back in 2017. From there on, we have series of workshops throughout Malaysia, particularly in southern, northern, east, and also our Borneo region. And then we have some hospitals after that workshops have already begun the services, such as in Kedah, the northern region up there. And then mostly in Selangor, we have 4 hospitals at the moment giving these services to the children. We have one in the East Coast, the Terengganu, and one in Pahang, the Central Zone in Hospital Temerloh. So in the Ministry of Health hospital, we have a clinical attachment following the workshops, and then optometrists who are proved to have skill and also knowledge in this field, they will be given a credentialing and privileging. Also, I like to give a highlight about one private hospital, the Damansara Hospital, which just embarked on this CVI service in January this year. So we are still in our baby steps of these CVI services actually. And during his early exposure to CVI, we refer to the textbook from the American and specifically from Dr. Christine Romalanzi. from the Perkins Vision Institute, and also some textbooks from the Gordon Dutton. Oh, let me give a also comparison between our setting comparative relative to other settings such as Australia, Netherlands, and New Zealand. We actually, my colleague and I, we went to Australia in 2018 to have the exposure at the Neverthong Special School, where in Australia at that time, they have that school is actually an adapted learning for CVI intervention for their school children. They have been knowing about CVI for almost 15 years old, 15 years. And at that time, we also encountered with our colleagues from New Zealand, where through this institution named Blends, BLENZZ, they have a integrated home setting with a school setting in a large compound, also with a CVI adaptation. Okay, and then they accept at that school and this institution from the children as young as newborn to up to 22 years old. And for Malaysia, we have begin in 2017, like I mentioned, so almost 4 years now. Basically, our services are at the Ministry of Health settings, and we are using this concept of home-based therapy, where we diagnose and also classify the CBI, and then we give the parents to undertake a home-based therapy with the children at home. So at the moment, we have children as young as 5 months to 17 years old. In the center there, if you see, it is the Batimius, which is located in Netherlands. It is actually, this institute has been running for almost 24 years. So at Batimius, they have everything from school to diagnostic to home setting integration, and everything is actually included at Batimius. So I went to Netherlands last year before the COVID strike. And we had an exposure and also knowledge with the sharing about how the Dutch people are actually giving the treatment to their children with CVI. Okay, now that's about the introduction. So before I start, I would like to have the poll, please, Mr. Fakhruddin, to know about your background CVI. Yes. How many of you have experience conducting assessment to classify CBI children? Right. So I could see there about 40% have some experience and another 60% never. So, all right, that's good. Now I will be like going to tune down my presentation to about 40-60 then, right? Okay. So this is what we're going to learn today. First, some recap about the definition of CVI. Second is how do we identify or classify these children? And third, what are the phases? What's the ranges for these CVI children? And lastly, what can we do as optometrists, as a person who, dealing with these children with neurological problem? As an introduction, some refreshment about our anatomy of the brain, perhaps. So we know that seeing is not actually relying just on the ocular, on the eyeball, on the retina, but it's beyond that. It is actually devoted to vision by the brain itself. So with the cognitive visual pathways, they are actually comprised of the dorsal stream and also the ventral stream. There are actually two streams are involved in cognitive visual pathways. So the dorsal stream actually runs between the occipital to parietal lobe, whereas the ventral stream runs between the occipital to inferior temporal lobes. So, and between these two, actually, there are integration between the two visual streams. So that's why the term, the more correct term to use here is cerebral, as compared to cortical blindness or cortical visual impairment, because the whole brain is actually involved in seeing and interpreting what we see. This is what each stream's functions. For example, if you look at this tree of vision, the dorsal stream will answer the questions of where. For example, it's a visual guidance of movement. to spot a distant object and to find object in a busy background. Whereas the ventral stream will answer the questions of what. So, for example, to recognize words, people, to recognize how people is giving a social cues, the expression, to know about route finding, and also most important is the visual memory. However, the functions of to look and reach at the same time, it is actually an integration of this dorsal and the ventral streams. So you can see all of those running from the eyes down there up to the two branches of streams. Now, what are the causes of CVI? It needs to be sourced from these five main causes, and it is actually must comes from the neurology or the brain itself. So first is any structural abnormalities like spina bifida, CNS, brain tumor, any demyelination of the white matter, cerebral atrophy, hydrocephalus, or microcephaly. Second is about this fetal distress or coma due to asphyxia or hypoxic ischemic encephalopathy. Third is infection, meningitis, tuberculosis, pneumonia. It can be from the mother during pregnancy or after the child is born. Fourth is a periventricular leukomalacia due to genetic mutation, infantile epilepsy syndrome, and things similar to this PVL. And lastly, is about hemorrhage. Hemorrhage occurs in the intraventricular, which is mostly due to a non-accidental injury in the eye and also brain trauma. Now, that's the main causes of CVI. Next one, let me show you how do we understand the CVI world by showing you this special slide that we encountered at Artemis Amsterdam last year. So this slide is very, at the playground area, it's very attractive because it somehow like make us understand what's inside the eyeball. So for us who are actually, knowing about the eyeball, without looking what's actually at the back of the eyeball, we can visualize already. Am I correct? So like if I give you this picture, immediately you know how it's gonna be look inside, from the back, or to the right or left, like this. But for children with CVI, or they will not be able to discriminate this 1 or 2D image immediately because of the absence of the ventral stream. Now, what about this picture? Could you find 10 hidden objects in this picture? There are actually a sheep down there, and then a tortoise. We got a rhino. We got a boar. We got a cattle, elephant, lion, and what's that? Deer, fish, and also a giraffe. So, in order for you to find these 10 hidden objects, it is very important first to identify the shape. Am I correct? The shape, the colors, you'll be like, finding whether this is same size or not, or whatnot. Anyway, I think from this, maybe some of you could notice a few, but you're still struggling to find some animals there. This is because of these objects are actually not in the same size, not in the same color, and they are actually camouflaged in their background. That is actually how a CVI children is seeing and experiencing their world. It's very, very annoying and very complicated for them. It is already complete in a complex background. You wouldn't notice that animals again, right? Now, let me explain about these visual behaviors, which is associated with children with CVI. There are actually 10 characteristics or behaviors that we need to look for before we be able to identify they do have CVI. the 10 characteristics are color, preference, movement, latency, preference on visual field, and then we've got complexity problem, absence of visual reflexes. They have non-purposeful gaze and distance view difficulty. And then the number 8 is novelty of a new thing. Second last is visual guided reach, and that one is the last one is the visual guided reach, seeing and also reaching at the same time. Now let's go quickly one by one. For color, now children with CVI, they have found that 50% of them are actually preferred at looking red objects or colors, and then follow with yellow, and lastly with a green, pink, blue, or no color preference at all. So for example, when we know that they have a color preference is by having that they are actually displaying a persistence in picking the same color of different types of objects. For example, for this child, we give them a box of balls, and for the first few times that she will always took the one in red balls and puts on the side of the next box. So this looks like she has the preference over red. That's the red ball that she's been persistently picking up every time, and we show a box of balls. And then we will always like thinking maybe that might be the color of her favorite, a color that her mother has imposed her to an object. For example, a duck, toys, this a brass toys like this. We always impose to our children that a duck should be in yellow color. Am I correct? But for children with CVI, even though that the mother may have some influence on saying the duck should be yellow, but they will have this preference on the red duck instead. So this is very interesting to know. Second is about movement. They have more responsive when we show an object that moves. It can be a pinwheel, like with multiple colors, and then with like a shiny materials, balloons, or the mylar lamp, the lava lamp. So anything that gives the impressive of a movement will attract the attention of a child with CVI, from not looking to looking, from being upset about something to giving a response to something. So let's see this picture or video of our child. We actually got all the consent from the child that we present in this. I present in this slide. So with this video, you could see that she has more responsive when the father is moving the pinwheel. If even the pinwheel is not moving from in a circle, but when the father is moving the location or the pinwheel itself, she started to look back and have lost attention for a bit. So that's one example how movement is a example as a evidence that the child with CVI is experiencing. At the same time, with this movement, it is also associated with latency. Latency means delay in response. That's why when we move the object and test the child with CVI, we will always look at how they are actually responding. Is it like very immediately, or is there a delay of 5 to 10 seconds before they get the attention to the an object? Same goes to movement as well. So movement and latency are actually interrelated, because the movement when it is lower, it will definitely will attract the attention more. Now, stop one. Next one is the visual preference. We know that our visual field is actually related to our brain with the processing of the optic nerve, optic tract, and the geniculate body. With And then if anything happens to any of that structure, it will give a definite of visual field defect. But however, this is not true for children with CVI, except if the child is having a trauma, need to undergo a surgery, for instance, that will be quite definite with their preference. But other than that, their field preference is actually not certain. They will be having a constricted hemianopia and inferior field loss for no reason. And then for this child example, he is having a persistent preferring on a certain field, which is on the right field only. So when we ask him to pick up the candles in front of him, he will persistently only taking those on the right side and just neglecting the ones on the left side. So that's how a visual field preference can occur in a child with CVI. So in that sense, we try not to present an object in the lower field so that if the child will be able to acknowledge or to be more responsive on the object that he should be giving response. What about complexity or the background busyness? For example, a child with CVI, when they go to a busy fun fair or a playground like this, they will feel very insecure because first they will not able to locate their parents. Even the parents are actually at their back. The complexity can occur in array, in the forms of noise, and also the surface itself. So it can be a three means of complexity. So we need to make sure that the child with CVI will not be exposed to such a busy environment. So with this kind of child, they will prefer a playground without any like many people at the playground. And also for our child that we had at our clinic last time, even though that she has a vision of 6/12, but when we put the candle, this little candle, on a busy surface or material, she will not be able to pick up the candle in front of her. She was like searching and trying to scratch on the background with her hands and fingers in order for her to identify whether the candle is actually above the material, or is it like the background itself. So that is also one of the interesting to know. And actually, this complexity plays a major influence to a child with CVI. What about the reflexes? We know that there are two reflexes that is innate to children, the Meniere's reflex. So we need to test whether a child with CVI has these problems with real visual reflexes, touch reflex and visual threat reflex. Touch reflex will be simply by giving a quick tap on the bridge of the nose, and the eyes actually need to be what you call voluntarily blinks and shut. But this is actually absence in children with CVI. So we call them like having a doll's eye reflex instead. And we know that this blink to threat reflex is actually a cortically mediated and requires an intact primary visual cortex. So, however, most of the children with CVI have an absence of these two visual reflexes. And this is not something that we can do to train them to develop again the visual reflexes. What about the non-purposeful gaze? This is quite very usual that we see every time a child with CVI presented to us. They will be having complaints from their parents that saying their babies or their children are always looking through something, not fixing, and sometimes very very attract to the lights, to the sun, to the artificial lamp in their house. So this is actually very, very particular to child with CVI, because the children can be really mesmerized and distracted by the light sources. So, like our child here, two of the child that I show you in this slide, they are actually having this very particular response when they came to our clinical cubicle on the examination. Whenever we are not giving them any object to look at, they will quickly look at the light. Now, what about distance view? Distance views are always like being compared or confused with the child having a poor visual acuity. But that is not true, because uh, this girl that I mentioned earlier, having a visual acuity of 6 over 12, should be actually she'll be able to see that bear in the book that I showed from 1 meter away from me, because at first this child is actually, we put her 1 meter away on her mother's lap, and then I showed her to her this bear, two bears in the book. So instead of she be able to look from that 1 meter with 6/12 vision, remember, she needs to crawl into towards the book, and for her to able to locate what's actually that I am pointing. So this makes us to think that actually it is not about visual acuity, but in order for her to come closer to the object, it is actually give one the functions of magnifying the object, and then second, it is actually reduce the crowdedness in their visual field. So same goes to these two examples that I showed in this slide. First is, this boy, he needs to hold the toy close up in order for him to manipulate and to visualize what he is looking, in order for him to really engage with an object, right? What about the novelty? Novelty means new thing. Our nature, actually, for us, we will always like very easy for us to notice a new thing in our space. For example, if you have these three statues at your doorway, maybe near the book rack or your shoe rack. So you always know that you have three statues, all black. There are like multiple sizes, and they are all pets, right? So what happened if one day you walk through the same doorway, and then you notice something is different? Even though that you are not looking at that bookshelf, you can quickly notice, hey, something is not right over there. You will quickly notice there's actually a cat that is pretending to be one of the statue, right? So this is actually not happen to a child with CVI. They couldn't detect a new or novel thing in their environment. Now, I'm going to show you the visual guided reach example of this child, this girl that we had last time at HKL. So she was unable to reach, to look and reach at the same time or simultaneously. Remember in the first slide, I showed about the brain anatomy and the functions of the dorsal and the ventral stream. So in order for her to see and reach something at the same time, it needs both the integration from the ventral and the dorsal streams. So let's see her video. If you could see, notice what happened. Look, her mother is asking her to pick up the popcorn, and then she will pick up the popcorn without looking. Let me put it again. Play this. Notice she is actually scanning, and then when she wants to reach, she's actually not looking, but she knows where is the popcorn is. Now, the other thing that I would like you to give comments there, if you can, perhaps. What else that you notice in this video beside of not reaching and looking at the same time. I wonder if you notice that she's actually moving her head from side to side. So this means that by actually moving her head side to side will also give her the ability of movements, because when she moves, it's also making that the object is actually moving and her vision will be improved, because she needs an object that moves in order for her to respond better. Last one, to give you one play another time of this video, you will notice when she wants to see, she starts off having a moving her head, then stop, taking the pick the popcorn again. Right. So that is very important for a child with CVI, absence of visual guided reach, and also movement. All right. Now, now that you have known all those 10 characteristics, let's talk about the strategies, because these strategies actually give them hope for them to learn, to adapt to their life, and for them to live their life as much as normal as a normal child. Because usually before I know about CVI, um, there's actually a very traditional or conventional way that we always give children with CVI a long appointment after diagnosis, maybe 1 year, and then we give them a uncertain what we call therapy to them, to their parents. We just give the parents instruction about doing any um, random therapies at home with lights, with objects, anything that they would like think it is interesting to the child, and come back after 1 year. But after we know about there are actually a specific strategies, then there's not actually a random strategies that we are looking at. Let me start with this, because we know that the brain is actually not degenerative, it is actually regenerative. After a brain trauma, after an infection, after a hemorrhage. This has been lots of studying have been carried out in overseas actually. So this shows the plasticity of the brain. They actually, they were doing this study on rats, on rodent, but in these studies you can see that it's actually looking at that there's actually summary about motor skills learnings when given on a very structured way. So the structured way of doing a strategy is depends on few things. For example, the dose of the trainings, the relevance of the training into the daily life, meaning that if they were rodents, they need to be on like climbing, going into the wheels. So it needs to be relevant to the training to the daily life, and then about suitability to the age and goals of the child. And also lastly, the ability of the child to maintain a close attention to the task given. The second thing that we can summarize from the studies are that actually the 2 years of life are very critical, because they are actually where the plasticity are at the maximum, and then we can see the improvement within the first 2 years if we do any early intervention. Now, in CVI strategies, because we are referring to the American textbook from the Christine Roman Latency. She is actually a teacher. She's not an optometrist. She's a special visual impairment teacher, having a PhD in teaching a blind and particular visual impairment. So she made up a structured way of classifying children with CVI according this range. The range is actually started from 0 to, which is no visual functioning at all, up to 10, which is the near normal visual functioning. So from this range of 10, she divided into three phases together. So each phase will comprise of 0 to 3 for phase 1, and then phase 2 is range 4 to 7, and the last phase is from range 8 to 10. Uh, I cannot talk about how the range is actually classified because it's very, very technical. Um, in our workshop and during my lecture and training, we gave a 1 day course on this range and phases specifically. But for tonight, I want to give you the impression that when we already classify our CVI children according to this range, it is very, very clear for us to know that what can we do for this age phase of the child. For example, a child that has been classified in phase 1, our aim of the strategy or intervention is to build visual behaviors. From the child is not looking at all, from just staring at lights, from just laying down looking through the wall. We want to make sure that the child having a visual behaviors to look again, to have the routine on looking. And then what happens in the phase 2? Phase 2 is where we want to integrate the vision with function. So based on the skills that we have developed in phase 1, we advance them to phase 2 and then make sure that they can look and at the same time they have the know the cause and effect of what they are looking at. And then moving to the last phase is the phase 3 for a child with an 8 to 10 range. This is where we can see all of the characteristics of the CBI getting to resolve one by one, except for the last two is the visual reflexes and also complexity usually. And this is when we can use a minimal adaptation to the strategies. And at the end, we want them to incorporate all these adaptation skill and also their visual behavior, their functions into their real world, into their daily activities, so that they be able to function within their capacity. Now, oh, okay. I think that's what actually we have learned tonight. I think that's going to be the last slide. So what we have learned today is about the definition of CVI. So we must understand that CVI is not a reduction of visual acuity, but it is rather a visual dysfunction due to the problems in the visual processing pathways of the brain. And then how do we identify CVI? It is from the 10 characteristics. This is the 10 characteristics that you must know that you cannot miss in order to classify CVI. And then what else? What do we already learned tonight as well is the phases. Briefly, like I said, I couldn't explain one by one. So there are 3 phases in total, and with the strategies, the the CBI range must be according to the phases. And when we do the strategies, it must be tailored and specific to the children's ability. And then lastly, what can we do? We can detect and classify them earlier so that we can introduce the strategies and adaptation to the child so that there will be more hope for these children in our life, in their life, and also in their parents' life. Because from like I said, before there's no hope for them. They were told that the child perhaps can see one day, but now when we already give them a scale from 10, they will have this hope that the child today, when we assess, is at range of maybe 3. So when we give the therapy, we do the assessment again. When we know that they will be in a range of maybe 5, 7, and eventually graduate at range of 10. All right. So with that, I would like to say thank you for listening. And then if you need to email me, you can email to this email down there. And that's my reference for my presentation. And I'm happy to take some questions if you have. Thank you.
Okay, so thank you, Dr. Duratul, very much for that, wonderful presentation. And I think it's really important for us to know. I think the most important learning is the 10 things what you need to look for, right?
Yes.
That 10 things what you need to look for. Anybody can do, and you don't need any sophisticated instruments. You just need to get to observe. I think the observation skills and very little instrumentation is required.
Yes, true. Very true.
Okay,
Just
so
use the educational toys. Yep.
that's right. That's right. You just need some small, which probably you will have it in your pediatric clinic anyways, right?
Yep.
Okay, great. So let's look at the first question here. This is more towards the prescribing and management. But if you'd like to throw some light on your experience, whether yoga prisms will help these patients and what
Hmm. Um, no. As far as I'm concerned, because we don't use yoke prisms in our therapy at the moment. This is actually when we receive our referral from the ophthalmologist for us to undertake the CVI assessment to classify them at what range. They usually will undergo all those optics, binocular vision, all those refractive assessment. So they have ruled out everything. If the child, because most of the children with CVI presented with exotropia, mostly 65% from my memory. So if they need your prisms, if they need any correction, they will need to do that prior to see us before we do the assessment. So I don't have any experience particularly with these yoke prisms from my experience.
okay, yeah, great. And
Yep. Thank you, Rebecca. Yep.
yeah,
Next one, perhaps. Mhm.
yeah, what's the
Okay.
minimum age? What do you think? Yeah.
Okay, so this question from Pradeep. Actually, as when the child as young as newborn, you'll be able to detect and also assess the CVI characteristics, because in order for you to know that whether the child has CVI, you need to refer to their normal visual milestone. So, for example, if the child is a newborn, so you know that a newborn, what are the visual milestone that the baby should be portraying or displaying. So when the child is actually, when presented to you at maybe 6 months, you know that the child normally should be able to fix and follow, should be able to focus. So these questions for me, it is actually you need to always refer on the age of the child.
Yeah, so maybe we have to compare it with their age match
Yep, thank you. I hope that answers.
development. Yeah,
Yep, yeah.
and
Is there next?
yeah, we'll take one last question.
Mm-hmm.
And do you have any questionnaires or some gradings which you
Oh
can,
yeah.
as a learning or as a further
Okay.
reading for this? Yeah,
Oh, yeah, from Bush and Terry. So, because we refer to the textbook from the American by the Christian Roman Lanzi, so it is actually includes a two types of ratings. There are actually two instruments that we are using. The first instrument, the rating one, is they call it a cross rating assessment, which is assessing from observation, from interviews with the parents, and from a direct test on the children for all of the 10 characteristics. So it's going to be like testing all the 10 characteristics, and then from there, we'll be able to know on what rating the child is. That is the first questionnaire. They call it instrument. Rating one, and then the rating two is it is named as within CVI characteristics questionnaire. You can look up the book and find out the full assessment questionnaire there. So with this within, it will determine the severity of the CVI for each of the characteristics. For example, if the child has a color preference, so will be look at from that questionnaire how strong is the color preference. Can the color be minimized? Can the color be putting a distracted away for quite some time, or is it like always present? So the rating two will pay more attention on the severity of each characteristics. And from that rating one and rating two, it's going to be very technical because we usually do this rating with practical and clinical attachment
yeah,
for 1 day. So rating one and rating two should be not more a difference of 1.5 in scale. So out of that, rating one and rating two, we got the range, and then from that range, we know the child is belongs or categorized under what phase. So yeah, so we use that rating, and uh, for example, in the Australian and the Netherlands, they don't use this rating much because they don't do the therapy as we do for our children. We do home-based therapy. Whereas in their setting, they don't do because this is actually integrated already at the school setting and their environment that in their boarding place that they have developed because everything has been integrated. That is there answer the question? I hope. Yep.
Yeah.
Maybe it's gonna be another talk about this rating one and rating two. Yep.
Okay, great, great. We can surely do that. And regarding the yoke prism, I think
Yes.
the attendee is
All
mentioning
right.
that
Do you have
he has an experience, but it works well. But however, visual field test is done prior to that. So maybe we can look into that, and that could be something as a home learning for us.
yes, and then Rebecca also asked, what about using CVI inventory developed by Gordon Dutton? Oh
Mm.
yeah. Um, we also look at Gordon Dutton's inventory. It's actually much simpler as compared
Mhm.
to what we use at the moment. Because with that, the American style with therapy, they have been like using a more unique and customized approach in their therapy as compared to Gordon Dutton's approach. So the Netherlands, they with the Dutch people, they use this Gordon Dutton inventory most of the time.
I
So
see.
that yeah.
Great. Okay, great. So I think with that, thank you so much, Dr. Duratul, for your kind thoughts and giving us your expertise related to this topic. Thank you so much. And just for closing, the course which you were, the seminar or the training which you were mentioning, just for the interest, is it open to everyone? Can they contact you and you can guide them in certain ways? How to approach to do that?
Oh yes, send an email to me and my team. We have actually a committee in Malaysia specific on the CBI services throughout Malaysia, and then we work with the private hospital. It is actually the Ara Damansara Hospital, which I mentioned earlier. It is actually the first private hospital in Malaysia having cerebral visual impairment service in Malaysia. It is very conducive environment there as compared to other settings.
That's right. Okay.
Right. So I've answered this CBI inventory already just now.
Yes, yes, yes.
Yeah, we don't use Gordon Dutton much.
Much. Okay, great. So thank you so much, Dr. Duratul, and for sharing your thoughts and taking us through the whole topic of CVI. I think we all have learned something from this. Personally, me, I learned the 10. I probably knew three or four things what to look for, but I never knew
Yes.
that there were 10 things to look for and do the assessment. So thank you so
Yep.
much for doing the session for us.
Thank you so much, and thank you for having me today tonight.
Most welcome.
And yeah, I wish everyone good night
Thank you
and
so
good
much.
evening to those from India. All right.
Yeah.
Bye.
Thank you so much, everyone, for attending today's session. We do have session planned tomorrow. It's at a similar time, 7 p.m. Indian time and 9:30 p.m. Malaysian time. It's on therapeutic use of scleral lenses. So
Mm-hmm.
please do join if you are interested, and I'll hope to see you again tomorrow. Until then, stay safe, take care, and bye bye.
Bye bye.
Thank you, Dr. Vedu.